Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Wednesday, November 28th. It is time for another live drop-in support group meeting. Now, my purpose with this meetings is to make you so strong, so knowledgeable, so incredibly informed that you will be able to walk into any doctor's office and advocate for yourself, because that is our goal. You know, far too many, for far too long, and far too many times, including as recently as last week, we have patients who are told that IC is all in their heads, and that is simply not acceptable. And so my goal in these meetings is to give you so much information that when you walk into any doctor's office, you can kick butt. That's what I want you to do. I want you to be able to kick butt and be your advocate and be the leader, because you have to remember that you pay them. They don't pay you. You're the boss. And if you're struggling to get care, if you have a doctor who's disrespecting you, then we want you to feel empowered enough to go look for someone else who will take care of you. So hello, Regina. Hello, Cheryl. Very, very nice to see you. We are simulcasting live on Facebook and YouTube. So we'll just wait just a couple of minutes. Hello, Donna on YouTube. It's so nice to see you. It's been a weird day, man. I don't know about you guys, but you ever have one of those days where you just don't? I had the craziest dreams last night. Crazy dreams. And I've just been kind of all funky all day today. It's just very, very weird. So anyway, hello, Jerry. It's nice to see you. Now, you guys, if you do have questions, feel free to ask them. In the meantime, let me go ahead and organize myself here real quickly. I was a little late today because I was putting up something brand new in our store. We finally got copies of this book, When It Hurts Down Here, which I think is probably the best pain book I have ever read in 25 years. Brenda says she was just watching the last video. Very cool, Brenda. Hello, Janice. Good evening to you too. Good evening, everybody. I hope that you've had a good day today, and I hope that your IC is treating you well. My pelvic floor is not particularly happy with me today, and I don't really know why, but you know, sometimes we just have those moments, and we've got to ride them out. So we are going to be doing a couple of different things today. I'm going to talk a little bit first about physical therapy, but I also have a reveal, our first reveal of a new product that I think you're going to like. So the way I organize these meetings is the way I organize my in-person meetings. You know, I ran the Northern California IC support group, which was one of the largest IC support groups in the nation. We had 300 members. We did several conferences before I started the IC network. And I run these online meetings just like I ran meetings there. And that is, I'm going to spend a good 20 minutes first talking about new news and information that I think that you will benefit from. And then we're going to go ahead and do maybe a couple of reveals, discussion of a few things, and then we're going to take your questions. But I want you to remember that if you ask a question and I miss it, that's not your fault. I'm not disrespecting you in any way. It just means that it's scrolling through my screen so quickly that I can't get to it. Christina says, what kind of questions can I ask? Oh, honey, there's nothing inappropriate. You ask anything you want to ask. So you're asking about IUDs with IC? And you're absolutely, you know, listen, I have no shame. I'm happy to talk about anything, and I will, whether it's rectal pain or bowel movements or intimacy or whatever. You ask it. If I can answer it, I am going to answer it. So Christina asked, she has questions about IUDs with IC. You know, you have to remember that we have subtypes for IC. So we've got the 5 subtypes of Hunner's lesions, bladder wall driven, pelvic floor dysfunction, pudendal neuralgia, and central sensitization. And what you tend to find with patients who have muscle tension and or nerve tenderness, bladder pain, bladder tenderness, is we don't do well using tampons. Sometimes our muscles are just too tight to get it in there anyway. And sometimes IUDs can be a bit provocative. and they can be a bit irritating. And so you're really not going to know until you try it and see how you feel, but don't be surprised if it tends to bother you. I would kind of expect that, to be quite honest. Yeah. Okay. So feel free to ask your questions, but I want to talk about something first. We're just putting together my fall IC Optimist newsletter is actually at the printer now. And it's a kick-ass edition. I think you're really going to like it. We have an in-depth interview with Dr. Angie Storr. Hello, the author of this book. Incredible interview. Lots of good tips on pain management, stuff like that. But I want to talk about something that patients hide. I call them the dirty secrets of IC. And these are things that you might be going through that you are too embarrassed to tell your doctor about and or too afraid to talk to your doctor about. And so as an example, one of the things that we consistently see in a small group of IC patients is something called PGAD, persistent genital arousal disorder. It's where your nerves have become so irritated down there. And you know what? She has a really good picture of this in her book. Let me get this here. So here's the deal about the pelvis is there are so many structures in the pelvis that have pain nerves. All of those pain nerves center at the lower spine, and they collect together, and they even overlap. So we know, for example, that the nerves of the bladder and the nerves of the bowel end up being shared right at the spinal cord. So you've got all these diffuse nerves throughout the pelvis, and then they come together kind of in a lump at the lower spine, and then they shoot up to the brain. And one of the things that happens is it's hard for your brain to actually tell you where your pain is because you got a lot of nerves down there. It's hard to distinguish the subtleties of pain just because of the way our body is wired. So one of the things that sometimes happens is when you have pelvic pain, the nerves down there tend to become more sensitive. And some patients will end up with something that we call allodynia. And that means that a simple touch can hurt. The simplest touch can hurt. And so there are some women, for example, who have vulvodynia who cannot wear underwear because the underwear touching either their pubic hair or their skin actually provokes pain and discomfort, right? I know for me, I went through about a month where I had really extreme allodynia, and it was I was a wicked flare, my friends, just wicked flare. It's obviously gone. This is a temporary thing. But again, I call it one of the dirty secrets. So for me, you couldn't even touch my belly without me going, because it hurt, because the nerves were sensitive. The nerves had become sensitized. More nerves had become involved. So one of the nerves that can get really irritated is the pudendal nerve and or the nerves around the clitoris. And so what happens is you end up with this period, you go through a period of time where you've got this kind of clitoral irritation, and it's incredibly uncomfortable. It's really icky. It's a slightly arousing, but painful, and nobody wants it, and nobody would ever wish it on anybody. It'll creep you out if you ever have it. That, my friends, is a really important symptom to share with your doctor. But, we IC patients, any patient, we don't want to be told that we're sexual perverts because we have moments when our pain is so bad that our clitoris kind of gets a little funky. And so we tend to hide that. But you know what that is that's just the pudendal nerve being irritated. And they can do a nerve block to turn it off. And I will tell you that as that nerve calms down, that symptom goes away completely. I had it for like 2 weeks. 2 weeks. And there are some people who have it a little bit longer, but that's one of the things you absolutely want to share with your doctor. Okay. One of the other secrets, dirty secrets of IC is, gosh, is that the right way to, it's not quite the right way to say it. If you've ever been to a physical therapist the first time, you know that their job is to find what hurts, right? So when you go to a physical therapist, they're going to do a very gentle pelvic floor assessment. They're going to look at, you're going to have you walk down the hallway. They want to see if you're walking weird. They're going to look at your legs. They're going to look at your glutes. They're going to look at your core. They're going to look at your hips. They're looking for any weird muscle pattern. Like for me, when I had a new one done a month ago, my new physical therapist went, do you realize you're kind of walking to the right? Like I was kind of walking like this. And I had never noticed that before. And that was because my hips are not working together. So their job is to look for funky muscle patterns and muscle tension. And of course, they will always need to do an internal exam. And for a woman, that is a vaginal exam. And for a man, that is a rectal exam. Now, one reason why anybody might balk at this is if you were a victim of sexual abuse. And if you were, I want you to know right now, I'm giving you a big giant hug. I am so, so sorry that that happened to you. And it is completely understandable that you would not want anybody messing down there. I completely get that. And so some of you will actually skip any pelvic floor work out of fear and out of PTSD and out of shared memories and not wanting to bring any of that up. And again, this is a situation where I don't want you to hide it because, number one, physical therapists will work with you so gently. They won't even do internal work if you have a fear like that. But we still want you to go into the office and we want you to get evaluated, right? You know, remember, of the three subtypes, the Hunner's lesions, the bladder wall, the pelvic floor, the pudendal neuralgia, the central sensitization, the biggest subtype is pelvic floor. The majority of you actually do have muscle injury. And it's that muscle injury that is, in fact, driving your symptoms. And we can give you every bladder treatment in the book and you will not get better because that is not solving the fundamental problem. It's that when you have tight muscles, your bladder is not getting good blood flow. So yeah, again, we could give you Elmeron. We could give you all sorts of stuff. That's not going to fix poor blood flow. What's going to fix poor blood flow and good circulation is physical therapy, or at least muscle relaxation. So when you go to a physical therapist, if you have been a victim and you do have PTSD, just say that you've got some PTSD and you don't want to try internal work right now. You want to start with external work. You want them to look at your body, help you understand how you're moving. If you're showing any funky signs that would contribute to muscle tension, if you have one leg longer than the other, or if you have scoliosis, you know, your hips. I don't know if I can do. Let's see. How can I do this? Okay, let's do it this way. So here are your hips. You know, your hips. And oh, I can't demonstrate it. So you've got a leg walking, right? Leg walking. In my case, because I have scoliosis, my hips are unbalanced. So I've got one side that's rotated backwards and one side that's rotated forwards. And that is why when I walk to the right. And that is one reason why I have long-term pelvic floor dysfunction. So when you go to that physical therapist, they will be able to look for structural things like that that will help you. And yes, there may come a time when you will want to do some internal work, but again, you're the boss. You pay them. They don't pay you. You get to set the tone for the appointment. You get to speak out, say, I'm comfortable with that. I'm not comfortable for this. That's too hard. Not enough. You have the control here. But what I don't want you to do is I don't want you to hide from the physical therapist out of fear, because they can really help. You know, you have to remember that 20 years ago, we all thought IC was an incurable bladder disease. And it wasn't until 2008 that the National Institutes of Health released their data of a multi-center trial that evaluated pelvic floor therapy. And could pelvic floor therapy actually help IC? And the results were stunning. The pelvic floor physical therapy outperformed almost every other therapy out there. And it was at that moment that we all had to go, uh-oh, wait a second. Why would muscle therapy help if this is a bladder disease? Maybe this isn't a bladder disease. Maybe there's more involved. And if you go back in the books and you go back decades and you see how doctors have been describing this, they have long described muscles so tight, they're like tight guitar strings. Okay. And it really took one physical therapist, Rhonda Cotarinos, 20 years ago to go to her first IC meeting and beg them to look at the pelvic floor. And she was right. And let me tell you, they ostracized her. They gave her this was a Federal National Institutes of Health IC meeting in Minneapolis. I was there. They gave her the last spot of the day. Half of the doctors walked out and didn't listen to her. And now she teaches the classes on pelvic pain and pelvic floor dysfunction at the American Urology Association. See, that one voice that can count. She felt so strongly that muscle work could help patients that she was the genesis for this big national clinical trial that not only proved it, but now pretty much every IC clinic in the entire world now looks at pelvic floor. Okay. So I don't want you to underestimate the importance of looking at your pelvic floor. It's important. And if you've got some PTSD, completely understandable, no shame, no blame, but I don't want you to be afraid to go and at least talk to them. Okay. But here's the other thing is that there are many of you who have gone to the physical therapist once and never gone back. And you know who you are because I talk to you all the time. Why? Why don't you go back? Because it hurt. Because it hurt. Well, my friends, I want you to look at that very, very differently because during that pelvic floor assessment, their job is to find what hurts, right? So if they can push on your glute or anything like that and trigger some of your pain, hallelujah, giant success. And if they can do internal work, and you know, when they go internally, like if this is your pelvis and they've got their finger up your vagina or your rectum, they're going to touch muscles low. They're going to touch muscles at a mid-length or mid-depth, and they're going to touch muscles deeply. And they're just going to very gently stroke them. Now listen, if they can touch a muscle and reproduce your pain, hallelujah. Oh my God, tremendous victory. You know why? Because they found it. They found what causes your pain. That, my friends, is a tremendous victory. You should not be afraid of pain at that appointment, okay, at all. If you have pain during that examination, then you're onto it. You're onto it. We found it. You found it. They found it. And so don't misinterpret that pain as that you're going to have that pain at every other subsequent appointment. Because now that they know where it is, then at your next appointment, they're going to be more gentle. They're going to be more thoughtful. They're going to look at the area, look at contributing muscles. So like for me with my left side, it's my left piriformis muscle. It's my gluteus medius. It's my hamstring. It's my quadricep. They're looking at all the structures that kind of go to that one spot. And they're going to work on those. So that's the other really big thing that I just wanted to say today is I don't want you to be afraid of physical therapy because it hurt during your first appointment. If it hurt during your first appointment, hallelujah, my friends. That is fantastic news because they found it. And if you go back the second time and it hurts, you tell them, hey, I need you to back off, my friend. That hurts. I need you to be more gentle. Hey, we need to approach this a little bit more carefully here. And that's when the good work starts. And again, remember, you're the boss. They're not the boss. You are the boss. You pay them. So you get to direct the care you receive. And really successful physical therapy is when you are very verbal and you tell them what feels good and what doesn't feel good, and don't hide anything. And please, please, please do not be one of those people who says, you know, the physical therapist or your doctor walks into the room and says, so how are you today? And you say, fine. Oh, come on, you're not fine. Seriously, you're not fine. Tell them what you're feeling. Did it hurt in the car as you were driving over? Did it hurt when you pee? Did it hurt when you have sex? Tell them everything, because that's how you're going to get the best care. I've been working with a really, really, I have to say, one of the most challenging patients I've had this year, probably the single most challenging IC patient I've been working with this year. And she's in assisted living, and she's, you know, she's just a wreck, terrible pain, afraid to go to the doctor, afraid to go to the urologist. And she's got excuse after excuse after excuse as to why she's not going to do that. And as I said to her today, I said, listen, you're not going to figure this out on your own. You need some help. We've got 3 issues for her. We've got estrogen atrophy, possible Hunner's lesions, and she cannot pee without straining, which means her pelvic floor is screwed up. She's got a little urinary retention too. And rather than calling the doctor and making an appointment, she simply is just at assisted living crying, saying nobody will help her. And it's like, no, they will help you, but we need you to be assertive. Anyway, so that's one of the people that I'm working with right now. My heart really goes out to people in assisted living and retirement centers, even if they're young, because unfortunately you have very little control over your food. They were only giving her coffee in the morning. It's like, all right, give me the name of the dietitian. Let me call them, see what I can do to try to work this out. And that's something that we here at the IC Network will do if you're ever in that situation. All right. So again, please, please, please don't hide your symptoms. There's no shame in your symptoms at all. Hello, Susan. Oh, Susan took 2 months off of Elmeron and she's doing okay. Girl, awesome. Now, you know, Dr. Lowell Parsons is the doctor who invented Elmeron, the only oral FDA-approved medication for IC. And he was in a lecture that we gave on our website years ago, and somebody asked him, do I have to take Elmeron for the rest of my life? And he said, no, you don't. You just have to figure out if it's helping you or not. So how do you do that? What he said is just reduce the dose. So if you were taking 3 a day, well, he said, okay, take 2 a day for a week, see if your symptoms change. If they get worse, then yeah, maybe that full dose Elmeron's helping you. If they don't change, he said, reduce it another. Go to 1 a day for a week. See how you do. If your symptoms don't change, maybe Elmeron's not helping you. Stop it entirely. Why not stop it entirely? That's exactly what he said to do if you were trying to figure out if Elmeron is helping you. And of course, and pretty much with any medication, that's kind of the way that I operate, at least with my body, is I tend to be very slow and very thoughtful and very gradual with whatever I'm doing. And of course, you should know that we have now very solid research associating long-term Elmeron use with permanent retinal damage, eye damage, macular disease. I sent out an email earlier this week or late last week on behalf of the Emory Eye Institute, asking for IC patients to participate in their research study. And I'm so proud of you because they had 800 answers in the first 12 hours because of that email. When you participate in surveys like that, you are helping all of us understand and make advances in IC. So thank you, thank you, thank you. Regina asked, is quinine safe for ICers? The answer is yeah, probably. I drink tonic water. I drink a little tonic water every day for muscle spasms. I've never had a problem with quinine. I think the tonic water that is absolutely the best tonic water on the market is called Fever Tree. And they have a lot of different flavors and they're really, really good. So I think you could try. Again, I only drink, you know, it's a small little bottle, you know, a half-size bottle, like 8 ounces, 10 ounces. I wouldn't drink a whole glass of it. Well, I could, but you know. Anyway, I don't have any information that says that quinine is bad for us. Hello, Brenda. Hello, Cindy. Hello, Melissa. Hi, Cindy from Ottawa. Very, very nice to see you. Hello, Wendy. Hi, Taryn from Atlanta. Cindy from Columbus. Hi, Rebecca. Chris. Chris asks. Chris. Dude, you're so funny. Chris and I have lots of conversations about IC. He says, what types of seasoned potato chips are relatively bladder friendly? None. None. I don't go for that seasoning. You know, I mean, most of that is artificial flavoring as well as perhaps extra salt, things like that. Man, if you want to have potato chips, just have Lay's potato chips. If you want to have dip with it, make guacamole. Avocados are fine for IC, you know, but I am not a fan of sour cream and onion or barbecue chips or anything like that. Number one, they're heavily preserved. And number two, they tend to be spicy and can irritate the bladder. So I would pass on all seasoned potato chips. I don't watch Santa Barbara, so I don't know anything about that. Cheryl says Desert Harvest Aloe is helping. Awesome. Really, really glad to hear that. Hi, Dee. Dee is in Aleut. Is that Alaska? Terry says, I have what they consider mild scoliosis. I sound like you. All of my other problems are right-sided. Doctors never wanted to make a relation to that being from scoliosis. I'll show you. I'll show you my scoliosis. I got no shame. I'm happy to show you. I'm going to bend over. So I'm going to bend over, and you're going to see that one side of my back is higher than the other. I have an S curve. I have a perfectly balanced S curve. So when I stand straight, you have no clue that I'm supposed to be an inch taller, right? So let me bend over. Right? And can you see that? You see that one side is higher than the other? I often say if there's one thing I could change about my health, actually it would be to fix that scoliosis because it's annoying. Because my waist is all compressed. That's where my height should be, right in my waist area. But anyway, not that you need to know that. I washed my hair today and it's very fuzzy, which is why I'm messing with it. Okay, Laura just had her pelvic floor assessment. She said the muscles are tight. Hope she can help. I have to wait 3 more weeks until I can get an appointment. Is pelvic floor dysfunction something that will go away, or will I have to deal with this for the rest of your life? It will go away if you work with it, but you have to work with it. And believe it or not, the appointment with the physical therapist isn't the most important part of that work. It's what you do at home. When you get home, that's important. And I say that because I myself am somewhat passive aggressive about doing my home exercises. Just telling it like it is. I just am. But Laura, you need to invest in a couple of books. Let's see here. Okay, so that you know what to do at home, I would encourage you to get this book, Ending Female Pelvic Pain, by Isa Herrera, who's one of the best physical therapists in the world. She practices at Renew Physical Therapy in New York City. She's very big on Facebook. She does a lot of live chats on Facebook. For men, we have Ending Male Pelvic Pain, also by Isa Herrera. And the cool thing about these books is that they're just jam-packed with things that you can do to work on those muscles. You know, pelvic floor dysfunction can be triggered after many different types of events. It can be triggered if you were an athlete in childhood, if you were a football player, if you were an ice skater where you fell a lot of times, or a gymnast a lot of times, or if you fell and broke your tailbone or hit your tailbone, or if you were a bike rider, or if you were abused, or if you had a baby and had some muscle trauma as part of the delivery. There are lots and lots of things that can cause pelvic floor injury. And so your goal is to find the injury and remember that when a muscle is injured, it gets weak. And because it's weaker, it struggles to do the job it's supposed to do, so it gets tight. And that's why you end up with funky tight muscles. So with the scoliosis, Laura, what the new physical therapist that I'm going to that I really, really like. So again, I've got one side rotated backward and one side rotated forward. what he said is that the right side has overcompensated for the left side, which is why the left side is weaker. And when I walk slightly to the right. And so what we're trying to do now is we're trying to activate that left side so that I walk straight. Again, you would never know. It's very subtle. And it's interesting because since I've been seeing him, I'm having a lot of back pain because it's rippling up my back, and we're trying to get all those muscles to behave normally. But that's because I have scoliosis. So, all right. Reese says, I went to several physical therapists that were uneducated idiots. Yeah. But I also did not have a diagnosis until you finally got to a physical therapist who specialized in pelvic health. And she did help, but the muscles go back to being tight when you don't follow the diet well. The bladder and the pelvic floor are very connected. So that's true. Okay. So if you've got a bladder wall injury and your bladder is screaming in pain because you've been drinking coffee, like the woman I was telling you who lives in assisted living was drinking a very strong coffee every morning, that's going to irritate your bladder and your bladder's going to hurt. And how does your body respond to that? It's called the guarding reflex. Your muscles in that area are going to get tight. And so, on one hand, we have to try to eliminate the source of the pain, which would be your bladder, if your bladder is contributing to it. But then it's also going to be, if they do get tight, you knowing what you can do to relax them. Okay. Which is, again, stretches. There is also one other book that I really like called Heal Pelvic Pain by Amy Stein. She is also a physical therapist in New York City at Beyond Basics Physical Therapy. So between Isa Herrera and Amy Stein, you get a good shot on the East Coast. If you're on the West Coast, they have a lot of really good physical therapists on the West Coast. In LA, in the San Francisco Bay Area, Nicole Kosian, who was our 2017 Physical Therapist of the Year in IC Awareness Month, is the author of this book, The Interstitial Cystitis Solution. She's on the board of the ICA. And this is the first book that really explains the bladder pelvic floor connection well. And as you can tell from my post-its, it's a very, very good book. And so she talks a lot about what you can do with your issues. And again, kind of getting back to that concept of being embarrassed. When you start learning about your pelvic floor, you're going to look at some weird pictures. Don't shy away from them. I don't want you to shy away from pictures like this, right? So this is a picture from the ground up of your pelvic floor. So for a woman, we've got a vagina and we've got a rectum. But look, we've got levator right here. We got these low muscles right here. It's so hard for me to do it this way. Okay. Levator ani muscles here. Then we've got some muscles that go this way. We've got muscles that go this way. Any one of these areas can be injured in some way, and they all require slightly different or very different physical therapy. So don't be afraid to look at these and have the physical therapist show you where your injury is. That's really important. Allison responded and said, with massage and retraining, it can be corrected. That is very, very true. When Dr. Christopher Payne wrote his 5 subtypes of IC, one of the points that he made is it's very unfair to tell patients this is incurable, because guess what? Pelvic floor dysfunction is entirely curable. But you have to do the work. Number one, you got to find the injury. And number two, you got to do the work. And if we catch that injury soon enough, when we rehabilitate those muscles, you could be an entirely new woman or man. And we see this over and over and over again. Muscles are trainable. There's something called muscle memory. Right now, your muscle memory, if you've got pelvic floor dysfunction, is tight. Our goal is to get that muscle memory to relax and release and be normal again. Allison says, can Elmeron actually cure IC, or is it a temporary fix? You're not understanding what Elmeron does. Just by asking that question, you're not really understanding what Elmeron does. So let me explain it here. So here is a side view of the bladder. And this is an Elmeron educational postcard. They don't make these anymore, but I got a bunch of them. So, all right. So this is a three-dimensional picture of the bladder wall. So at the top of the bladder, we have what we call the gag layer, a nice layer of mucus that acts as a barrier between what's in your urine and the cells beneath. Underneath the gag layer, you've got 4 to 5 layers of urothelial cells. And what's interesting about these is these are the largest single cells in the human body. They're monster cells. They're so big that when one is damaged, it takes 2 weeks for the next one to fill in that spot. These are giant cells. They look like a beehive under an electron microscope. It's fascinating. And then underneath this layer of cells is we've got blood vessels and we've got nerves and mast cells and things like that. So if you've got IC subtype 1 Hunner's lesions, you have basically open wounds in your bladder. And when you have an open wound in your bladder, look at this. The irritants in your urine get right where they're not supposed to be, right into these cells. And that's what causes all of the irritation and all that sort of stuff. So with IC subtype 1, urine can get where it's not supposed to be. And the same with IC subtype 2. If you've got chemotherapy-induced cystitis, if you've got a damaged bladder wall from drinking too much diet soda, or you have another chemical injury, or if you have an infection, all of those things cause holes where urine gets into these tissues and causes problems. Causes mast cells to release histamine. Histamine then triggers the nerves, and the nerves get very irritated. And then you've got the nerves releasing something called substance P, which causes physical damage. And then the substance P causes histamine to the mast cells to release histamine. You get in this really vicious cycle of irritation. So what Elmeron does is it puts a temporary coating on your bladder so that irritants cannot get in there. But that's not a cure. A cure would be if your bladder regrew mucus. If we can get your bladder to regrow good, healthy mucus to protect your bladder, and you cooperated by not drinking massive amounts of acid, which, are going to damage even a healthy one, then healing, that creates an optimal environment for healing. It's all, you really have to think of this as injury. Your goal is to create an environment that will support healing of the bladder wall. The bladder is like your stomach. You know, if you have an injury in your stomach, the problem is there's acid in your stomach. And getting that to actually physically heal takes time because you got to deal with the daily acid irritation. Your bladder is kind of the same way. The challenge with an injury to the bladder is you've got urine in your bladder all the time. And urine is irritating. And it takes time because you've got these giant cells down here. So healing is always happening. I mean, that is the miracle of the human body, is it is designed to heal. Your body right now is trying to fix whatever is going on. Our biggest challenge is that we often get in the way of healing. And the way we do that in many cases for IC subtype 2 is diet. You'd be you kind of have to remember that your bladder and your body was designed for life tens of thousands of years ago. They weren't drinking coffee tens of thousands of years ago, or orange juice or cranberry juice or anything like that. They were drinking water. And so one of the things we kind of have to ask ourselves is has the bladder had the opportunity to adapt over time to create defenses for acid? And the answer is no, not really, because it takes 5,000 years for an evolutionary adaptation to occur. So our modern industrialized food is not necessarily helpful and can be quite harsh on the tissues in our body if you do it over and over and over again. And the perfect example is Mountain Dew. I mean, Mountain Dew is devastating. And if you saw that it wasn't 60 Minutes. It was one of the other shows. doing a problem with dental hygiene in Appalachia, and that you had babies whose teeth were coming in rotten, and people in their teens and 20s having to have all their teeth pulled out because their teeth were black and filled with cavities. And what it ultimately came down to is that they couldn't afford milk and they were drinking Mountain Dew every day. And the corrosive effect of that Mountain Dew was staggering on their bodies, absolutely staggering on their bodies. It was an ABC special with Diane Sawyer, kind of like 10 years ago. All right. Alexa says she needs to be more firm with her urologist after a second cystoscopy. He said no need to follow up with him. As an IC patient, which is confirmed, I feel a little lost. I rely on home remedies, natural treatments. I think he just doesn't think much of IC. Alexis, you know what I would do in that case is I would send you over to the American Urology Association website to their IC guidelines. And I would have you print them out, read them, bring them back to the doctor and say, I would like to explore these treatments in their existing order with my IC to see if we can figure out, number one, where is my pain coming from? Is it my bladder? Is it my pelvic floor? Is it Hunter's lesions? Or if you're like me, do you have a completely normal bladder, but you have central sensitization, IC subtype 5? That's a key critical subtype here. IC goes back in my family 3 generations. And when you look at my bladder, as they did last year, my bladder looks entirely normal. And yet there is no doubt that I have IC. No doubt at all. I mean, I'm through years of pain with my bladder. So why do I feel discomfort in my bladder? Because I have central sensitization. It means I inherited central sensitization. That means I've got super sensitive skin. I've got a sensitive stomach. I got a sensitive bowel. I got a sensitive bladder. I got a sensitive vulva. I've got a sensitive rectum. It's the way I'm wired. And it's not a disease at all. It's just, hello, my family is from Norway and Sweden. And what was their life like 5,000 years ago? World's blandest diet, and they just didn't have a lot of the stimulants we have today. I personally think that through evolutionary adaptation, they actually favored sensitivity because I think that meant we could smell food, we could find food. The world needs sensitivity. But life in 2018 and soon to be 2019 is hard for those of us who have a nervous system which is simply easier to turn on. And I've talked about that in other lectures. I'm happy to talk to anybody about that if you have any other question. Taryn says, my urologist pushes and pushes Elmeron, same exact sales pitch every time, literally like she's mentioned it. Well, and what you can say to her is, Elmeron, I'm concerned about Elmeron because it has numerous side effects, but even more so, I cannot afford it. You know, I was on, where is it? Hold on a sec. Let me get my iPad. Hold on a sec. Okay, so I found a cool new website, totally cool new website. And I've got it saved here on my iPad. Let me get it. You guys have to go here. Hold on. This is a website that will help you not only find the costs, the current costs of medications. Oh, no, where is it? It didn't shut down correctly. Here it is. GoodRx, GOODREX.com. And here it is. So you know, because we have a lot of people who call about Elmeron and they just can't afford it. And so this came through one of my medical feeds. And what they have is the price of Elmeron, not only monthly, but also every 3 months. And I was curious if there were any pharmacies that were selling Elmeron for under $1,000. And what they have is they have a coupon at Costco, Albertsons, Safeway, and Vons. With your free coupon, it will go from 1,000 to, I hate to break it to you, 800, 823, right? And then a 3-month supply, even with the coupon, makes a prescription of Elmeron something like $2,400, $2,500. So, I mean, seriously, who the hell can pay that? I can't pay that. I cannot pay that. I can't do it, which is why I've never taken Elmeron. Nor do I have any intention of taking Elmeron, nor do I need to take Elmeron because I'm IC subtype 5 central sensitization. And my bladder has a protective coating. It's just the nerves under here that are super sensitive. Now, would a barrier give me a little of extra protection? Maybe, but Elmeron wouldn't be my first choice. My first choice would be Cystoprotect, right? Or Cystorenew. Number one, it's cheaper. And number two, there are less side effects. So anyway. Rebecca says, I just found out that I'm suffering with hypothyroidism and pernicious anemia. I'm wondering if these conditions would affect my bladder. You know, the low thyroid is interesting because a lot of patients have thyroid issues. And that's kind of, when we think about those subtypes, there's still subtypes yet to be defined. And that low thyroid is probably in another subtype, or IC subtype 5. I am low thyroid also. With the pernicious anemia, my mother, who has IC, also has pernicious anemia. And we've been doing, getting treatment for that for years. And she is finally now not anemic after 6, 7 years of being very anemic. And in her case, what they found when you have anemia, that means your body's bleeding somewhere. It's bleeding somewhere. And you're losing red blood cells. You're losing iron. You're losing the very thing that your body needs to hold oxygen to move it through tissue. So they almost always do some sort of stomach evaluation to make sure that you're not bleeding intestinally through your stomach. And when they did that with her, what they found was that her stomach was fine, but underneath her stomach is another small sac called the undum. And the undum was filled with varicose veins that were oozing. And so what they did is they went in and cauterized them. And one doctor said that sometimes you see that with people who have Sjogren's syndrome. And another doctor thought it was because she was sucking. She had a terrible addiction to menthol cough drops. And she was doing like a little box of cough drops every single day at that time. And that was, we think that was also what was making her stomach bleed. So, Rebecca, I just want to say that the treatments for iron are usually fine on the bladder. She had iron infusions. There were no problems at all with them. She took iron pills, didn't mess with her bladder at all. They can be a little rough on the stomach, but in her case, they weren't rough on her stomach either. So don't be afraid of those anemia treatments. You're just going to talk to your doctor about it, start slowly, see how you feel. And if you have any issues, let your doctor know. Isabella, down on YouTube, let me move down here for a moment, then I'm going to come right back to Facebook. What is the typical dose of hydroxyzine and amitriptyline for IC, and how long do you have to take them? All right. So for both of them, you kind of function from a less is more perspective. So with, for example, the amitriptyline, which is a low dose antidepressant, The normal dosage for, if you were using it for depression, is, I think, 75 milligrams a day. But for IC, because you're not necessarily taking it for depression, we're taking it because it can calm some of the nerves. You normally start at 5. One of the challenges with amitriptyline is it's notorious for causing a lot of side effects: dry mouth, dry eyes, irregular heartbeat. That's why I couldn't take it. It really messed my heart up and gave me a very, very irregular heart rate. I can show you this though. Let me show you why those are viable, why the doctor thinks that those are viable. This is our summer IC Optimist magazine, one of our better ones of the last 5 years, I have to say. And in this magazine, I review the class on IC that I took at the American Urology Association with all the other urologists who attended. These are urologists from around the world. This was taught by Robert Evans, Robert Moldwin, 2 doctors on our medical board who are the best in the world in IC, in my opinion. So this is one of the graphs that they share, one of the slides that they share. And let me just try to go through this with you, okay? So we have at the top a bladder insult. Something has injured the bladder, and it has caused damage to the bladder wall, epithelial layer damage, which then allows stuff such as potassium to penetrate into the bladder wall. When the bladder wall gets irritated, nerves get turned on, the activation of the C fiber nerves. And you'll see, and I don't know if you can see this, that's where they say you take something like amitriptyline, because that tricyclic antidepressant helps calm the C fibers down. So when the C fibers get irritated and they release substance P, that then irritates mast cells. And the mast cells release histamine. And you can see over here, that's where they say you use an antihistamine like hydroxyzine. And you get stuck in this vicious cycle here. You've got mast cells releasing histamine, which irritates nerves. The nerves get irritated. They release more substance P, which then irritates mast cells, right? So you're taking the low-dose antidepressant to calm the nerves down. You're taking the antihistamine to calm the mast cells down. And in both of those situations, you're always going to start with the lowest dose available. So 5 milligrams. And in fact, who was it? God, who was it? It was one of the big IC doctors who was in our lecture series. He said that sometimes he just has people cut it in quarters or even smash it and start with grains if they're really, really sensitive to it. And then again, you might just stay at that lowest dose, or you might titrate up. It depends upon how you're reacting to it and how it feels. But that's exactly why they would tell you to do an antihistamine and an antidepressant. They work in 2 different ways, and they're attacking key parts of that whole irritation process in the bladder. I could not take any antidepressants. They had way too many side effects, but I did take the hydroxyzine for years, and I love that stuff. I took it for 10 years. The only reason I stopped it is because it started giving me nightmares, and that's what hydroxyzine does. I want you to know that there are 2 forms of hydroxyzine. There's hydroxyzine hydrochloride, known as Atarax, and hydroxyzine pamoate, known as Vistaril. Atarax is more difficult for people who are sensitive. The pamoate, the Vistaril, is a much gentler formula that most patients do better on. So if you're one of those people like me where you're super sensitive to meds, you're going to go right to the Vistaril instead. The lowest dose of the Vistaril is 25 milligrams. What my doctor had me do was cut the capsule in half, pour half in one side, half in the other side, just take half. And that's what I did. It was remarkably helpful. Hydroxyzine has what we call a beneficial side effect. It also has a lovely anti-anxiety effect. And if you're in pain, you're anxious. And that was one of the reasons why I liked that medication so much. But hydroxyzine does have the potential of affecting your dreams. We call them hydroxyzine dreams. So you have really vivid dreams. So if you're having a sex dream, believe me, it's going to become the best sex of your life ever, ever, ever dream. And if you're having a nightmare, it becomes a night terror. And night terror, that's why I stopped it as I started having night terrors. D, it is a privilege to know you. It is an absolute privilege to know you. And thank you for sharing that your father is an Aleut from Sandpoint, Alaska. You know, one of the things that some people find interesting is when we ask what are the risk factors for IC and we look at heredity, you know, the early studies really were pointing to European ancestry. And I think that that makes sense for central sensitization, et cetera, et cetera. However, we did have one small study that was done. It was the name of I don't remember the name of the doctor. It was done in Oklahoma, which actually found that there was a population of Native Americans who also seem to be more at risk for IC, specifically Cherokee. I don't know if anybody's ever studied Aleut. But again, if we go back ancestry, your ancestry and mine had an absolutely similar environment. Mine were at the Arctic Circle in Norway, and our bodies were designed for life with a very simple diet of seafood and maybe berries and salt. And our lineage was not exposed to coffee. Our lineage was not exposed to chocolate or orange juice. Unlike somebody who, for example, was born with a Central American ancestry or an African ancestry. So there's really interesting kind of ancestral questions that I love to think about and I love to explore, because it really helps us understand that none of this is our fault. Having these funky sensitivities is not our fault in any way, shape, or form. I don't want you having any shame, any blame about this. Again, for people who just came in, my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the country, I do believe. And I now run the support groups on the IC network after running the support groups in Northern California for many years. And this is my job. All right. We do support group meetings twice a month, first and third Sunday of the month, 12:30 Pacific time. That's our scheduled one. And then I do drop-in meetings during the week when I can do it, when I don't have other work to do. And this is a drop-in meeting. Mary Roma says, do you think scoliosis is related to IC? I think scoliosis is related to IC subtype 3 pelvic floor dysfunction. Yes, I do. Laura asks, do you think acupuncture can help with tight pelvic floor muscles and pudendal nerve pain? Why not? It's absolutely worth a try. Remember, we have got something called Urgent PC, which is the Staller afferent nerve stimulator, or PTNS, the post-tibial nerve stimulator. And I was one of the early patients for that at UC San Francisco. And if I can, I always have trouble showing you. I don't know if you can see that or not, but there's a little black spot right there. And that is the tattoo that they put on me to show me where to put the needle in when I did that stimulation at home. I've got them on both sides. And that is indeed the SP6 acupuncture point. And they use an acupuncture needle as a vector to that nerve. Here, hold on. My chair is being weird. All right. Okay. I will tell you, though, Laura, that when I tried whole body acupuncture, it was a little too much for me. It was like my nervous system was being overstimulated. But when I did little pieces of acupuncture here and there, that was much better than doing a whole body approach. I just think my nervous system was terribly overloaded by that. Ravonda says her subtypes are close to mine. She's got central sensitization, bladder wall, and pelvic pain. You're going organic. Also looking at non-toxic, clean cosmetics. But notice that they contain things like vitamin C, rosehip, green tea extract, orange peel oil. After researching it, seems the skin absorbs what is on it. So I was wondering if some of these ingredients could get into your system and into your bladder. You know, not in any great degree. You can't compare putting a vitamin C, a mask peel on your face to drinking a glass of orange juice. So I wouldn't worry about that so much. However, I would be very, very careful with the green tea extract because the US FDA, I think a month ago, released yet another alert about green tea extract causing liver damage. It's just, remember, it's so tempting to kind of believe what companies say about your body needs this product to be healthy. And you kind of have to ask yourself, all right, did my ancestors have this 100 years ago? And if the answer is no, then why would you do a lot of it? And green tea, I will tell you, is agonizing to a bladder. If you're drinking any green tea, for God's sake, stop, especially if you got Hunner's lesions or bladder wall driven. It's remarkably aggressive to bladder tissue, not only because of a very high acid level, but also because it contains caffeine. And now we know that green tea extract can actually cause really significant liver disease. Manda says, I have ESB and I was admitted, and now you have a PICC line for high dose antibiotics. Egads, girl. I hope that you're feeling good. That's big time. You're doing some big time antibiotic therapy. Very interesting to talk with your doctors about probiotics and what they want to do to try to help protect and, if not restore, your biome, the normal beneficial bacteria in your gut and your bladder that those antibiotics will have killed. Be very interested to hear what they say to you about what you should do for that if they want you taking a probiotic or prebiotic or anything like that. Julie says, I live in a state where there are no doctors who know anything about IC. What should I do? Well, Julie, you're going to travel. You're going to travel. If you don't have any doctors who don't know about IC, I mean, you got two theories here. You got two things you can do. You can be the educator. So again, if you go over to the American Urology Association website, and I got the URL right here. I got all my slides right here. Let me find it. Okay. I want you to go to this website. This is the American Urology Association, auanet.org. In the upper right-hand corner is a link called Guidelines. I want you to click on that link. You go onto the guideline page and then search for interstitial cystitis, and it will pull up the IC guidelines that they released in 2011 and edited and revised in 2014. I want you to print out 2 copies. It's 60 pages long. Do it. Print it out. I bet 3 copies. 1 for you, and I want you to read the whole thing. Because if you read that whole thing, you will know more than any other doctor in your state about IC. I want you to have a copy for your gynecologist, and I want you to carry a copy with you if you ever have to see a new doctor, so that you walk in with the bomb. You walk in with everything you need to know about how IC is treated. And you're not saying, hey, I got this information from the internet. What you're saying is, I got this information from the American Urology Association. These are their guidelines for IC. Can you please read them? Because I would like to treat my IC based upon their recommendations. So that's option number 1. Option number 2 is you do get to the point where you exceed the experience level of local doctors. And if you've been seeing a local doctor 2, 3, 4, 5 years ago, and that doctor just keeps saying Elmeron over and over again, or they're saying, I don't know what else to do with you, et cetera, that's when you go to the next level. You go to a regional doctor, and a regional doctor is usually at a university in your state. Like for me, I'm in Santa Rosa, California. I went to UC San Francisco, which was 70 miles away. And then if I did not have success at UC San Francisco, I would have gone to a national doctor. And that's the traveling. Because frankly, listen, if you've been suffering for years, we need to fix that. We need to fix that. You deserve to go to an expert who knows how to treat you correctly. Even if you just go once, It will change your life to be able to walk into a doctor's office who gets it, who understands it, who doesn't criticize you. They welcome you. They know the right questions to ask. They believe you. And again, they treat you with respect. And there are kind of 5 key national doctors that I think are worthy of second opinions. So on the West Coast, if you're on the West Coast, it's going to be Chris Payne at Vista Urology in San Jose, California, or Phil Hanno at Stanford University. There is also an IC Research Center at the University of Seattle up in Washington. If you're in the middle of the country and of the United States, your best resource is probably going to be Ken Peters in Michigan. There used to be an IC Research Center at University of Oklahoma. It shut down. There is Dr. Carl Creeder at the University of Iowa. He is also of national renown. And then on the East Coast, you have 3 doctors that are truly exceptional. You've got Rob Moldwin in New York on Long Island. You've got Robert Evans at Wake Forest University in North Carolina. And then you have Dr. Robert Eckenberg, who is probably the top national pelvic pain doctor, and he's in Bethlehem, Pennsylvania, and New York City. So, you know, as I say to patients, and most patients say, I'll go anywhere. Please tell me where to go. You can't, don't hide at home. If you're not getting to the next level, if you're getting worse, if you're not improving, if you don't have treatments, that's hard that you hurt. The last thing you want to do is get in a car, but that's where you're going to get the help. So think about it. Don't be afraid of traveling. It's worth it. I went to UC San Francisco, I'm going to say 14 times because I did urgent PC there. Worth every time. Even when I got stuck in a traffic jam on the Golden Gate Bridge and didn't have access to a bathroom for an hour. Literally, I don't know how I didn't pee my pants. It was that bad. I was just holding it. It's the steering wheel holding it going, where's the bathroom? And that is why now I carry Travel Johns in my car and a pop-up tent. I don't know if I have any Travel John demos. Let's see. Well, I can show you something similar. So what do pilots do who are flying across the country? How do they pee? Especially in a small plane, right? They can't get away from the controls. Think of fighter pilot, because we got fighter pilots with IC that I've worked with. So how the hell do they pee while they're flying their plane? Well, the answer is they have a Travel John. They have something that they can easily use to pee in their chair. Obviously, that's much easier for a guy because a guy can use a catheter cath where you just basically put it over your penis and you pee into it and it goes in a tube into a bag. So what can a woman do? Well, so this is an example of one. This is called a Go Girl. And so you just ideally wear a skirt on a trip so you don't have to drop your pants, but this will fit very comfortably right over your urethra, and it has a tube, and it's kind of broken right now, but you will end up peeing into a plastic bag, and that plastic bag has a mineral in it that will instantly solidify so that you don't have liquid that you're worried that it's going to spill. So Go Girl is one, but the one that I think is better is called the Travel John. We sell it in our store. It's 3 for $7.50. So put a 3-pack in your car and you just don't have to worry about it. Then you can pull over on the side of the road, open your front door, open your back door. You've got your car on one side, you got a door here, you got a door here. Hopefully you're looking at a hillside and you can pee and nobody will know. Nobody will see you. Don't be afraid. Practice in your driveway if you have any concerns. Oh, Taryn said she watched that Mountain Dew special. Yeah, it was amazing. Manda says she can't live like this anymore because you're in so much pain with ESBL. So, hun, you got a wicked infection, my dear. But once they kill that infection, you should feel much, much better. And you're getting care for that right now. So carry hope in your heart, my friend. You are the perfect candidate for something called next generation urine testing. If you haven't done that already, next generation urine test is absolutely the best at identifying drug resistance genes. And good bacteria, bad bacteria, and even fungal infections in your bladder. And so you should ask, Amanda, ask your doctor if they've done next generation DNA testing, because that's a must for you now with you having such a severe UTI. Typical urine tests are not going to be as good at identifying funky infections. This will identify everything: good bacteria, bad bacteria, fungal infections. Remember, we now know that some patients having bladder wall flares actually have candida yeast infections inside their bladder, and that is from research by our own National Institutes of Health. So that's one of the reasons why this is so cool, is this will test for yeast. And it's only $199. So if you go to bladderhealth.org, you can watch some videos of some doctors explaining it. It's a website I built this summer because this is so life-changing now that we have it and it's affordable. This cost thousands of dollars a year ago. The companies have really brought the price down, which makes it real for you and me. Chris asks, if you stop taking the Elmeron, will the retinal macular dystrophy go away, hun? That's a question for your ophthalmologist, hun. You got to ask your ophthalmologist that question. You guys are so good at supporting each other. Well done. D says, I've been on Elmeron since 2001. When I do not have it, your bladder rebels. I have followed the IC diet. You're also on hydroxyzine. When I had my stroke, they took me off Elmeron and my bladder rebelled like it was when I was 2001. Yeah, I mean, there are some people that Elmeron works very well for, no doubt about it. There are some people, however, who cannot tolerate it or who develop side effects for it. Luckily, we have products like this, Cystoprotect, which was invented by another IC researcher, Dr. Theo Harides at Tufts University. This has a similar mechanism of action to the Elmeron, where it acts as a bladder coating, but it doesn't come with the side effects. So Dr. Lowell Parsons, who invented Elmeron, and Dr. Theo Harides, who invented Cystoprotect, appeared at a conference in 2006, and they talked about this. So Dr. Theo built this kind of as an option for people who needed to get Elmeron. And so it might be very interesting for you to try this as an option. And what the doctor said to do at that conference was in San Diego, is do a 1-for-1 swap. So if you take 4 Elmeron a day, you can go to 3 Elmeron and do 1 Cystoprotect for a week. See if you notice any difference. If you get worse, then yeah, the Elmeron's is your product. If you feel the same, then we're on to something good. And then they said do a 2-to-2 swap. And then they would say go to 1-to-3. And that's kind of how you would very slowly transition from something like Elmeron to something like Cystoprotect. And that's straight from the doctors who invented it. Just in case you're curious, Cystoprotect is a brown pill, a brown capsule. What we tell patients to do with any supplement, especially those of us who are freakily sensitive like myself, is start with 1 capsule. Just see if your body likes it. If your body likes it, do 1 a day for a week. See if your body likes it. If it does, go to 2 a day for a week. If it likes that, go to 3, and you can go up to the manufactured recommended dose of 4. However, because I am freaky sensitive, when I went to 2, it gave me the runs. It gave me loose bowel. And I don't like loose bowel. So I did not push it past that. The last thing I want is diarrhea every day. So when I take Cystoprotect, I only take one a day. And you know what? That works for me. I take it if I'm having a flare sometimes, but my bladder's pretty good right now, so I haven't needed to take anything. All righty. Hello, Julie. I'm just checking here for questions, going back to YouTube. Hi, Susan on YouTube. You've been in a flare for 6 weeks with very little sleep and very little relief. The doctor wants me to do a cystoscopy with hydrodistension. All right. So I don't disagree with that because I don't like guessing. I don't like guessing. Man, if you're in pain and you're getting worse, there's no substitute for eyeballs on the organ. We want to make sure they haven't missed something. We want to, I've told the story that happened earlier this year that was so interesting. We had a woman who had very severe IC symptoms for a couple of years. And she was afraid to let the doctor look in her bladder. And when he finally did, he found a giant kidney stone, a calcium oxalate kidney stone with very sharp edges. And once they took the kidney stone out, her bladder healed and her symptoms went away. So there's no substitute for eyeballs on the organ. However, you have to negotiate how it's done. If you're going to do a hydrodistension with cystoscopy, the American Urology Association recommends a low pressure, short duration hydro. Low pressure, short duration. In the old days, they were pretty gung-ho. They thought the more you stretch the bladder, the better. Now we know the more you stretch the bladder can rupture. So now what the American Urology Association says is do not do high pressure, long duration procedures. We want to be as gentle and non-traumatic as we can to the bladder. So you're going to do a low pressure, short duration procedure. So that's what I would be talking with them about, okay, is how they choose to do it. I had one last year. It was low pressure. I had no issues with it at all. And also make sure that they take pictures and even better yet, a video. We want pictures for your medical record. So if you're going to do a hydro, a couple of things you need to know about hydro. Number one, low pressure, short duration. Number two, make sure you have a discussion about what they're going to do if they find Hunner's lesions. If they find a lesion in your bladder, you want them to treat it at that time. You don't want to have to go back a month later and have another hydrodistension. So normally, urologists will act at that time and treat the lesion. So you need to have that discussion with them because if he says, I'm not going to treat it, you're going to say, why? And what he's probably going to say is, I don't have the equipment to treat it. And then you're going to say, all right, who has the equipment to treat it? And you might choose to have your hydrodistension somewhere else. Okay. So have a discussion about any treatments that he might choose to do. And then I also think it's important that you have a discussion about pain care because when you stretch the bladder, it can hurt. And some people have a hydrodistension and they can go out to dinner that night and they are fine. Other people have a hydrodistension and they're laying in bed for a week because it hurts a lot. So I think it's very, very important ahead of time to have a discussion about pain care. I personally would choose not to do it if the doctor said, I'm not going to give you any pain meds. I think that's completely unrealistic. And during my uterine cancer procedures last year, I had a hysteroscopy, I had a D&C, and then I had a hysterectomy. Before the hysteroscopy and before the D&C, I told them flat out, I'm not doing it unless I have a prescription in my hand for pain meds. I need your promise that you're going to help me if I have a problem. I can't imagine not, and also don't do it on a Friday. The last thing you want to do is have it done on a Friday and then you go weekend with your doctor's office closed. It's important to have it on a Monday or a Tuesday or a Wednesday so that if any issues happen, you know that that doctor's going to be in the office. I think it's also worth asking, are you going on vacation? I wouldn't have it before the doctor goes on vacation either. I think you need to make sure you have the confidence in knowing that you will have a doctor available to you 24 to 48 hours after the hydrodistension if you have any issues. And the issues are going to be either pain management or infection. There are some people who actually get infections after a hydrodistension, a nosocomial infection. It's very common. Anytime you put an instrument up the urethra, you have the potential of introducing bacteria. And so that's my little rant on that. So, you know, this is not an aspirin Advil moment. I don't think anybody here would disagree with me. If you've had pain after hydrodistension, having a couple of Norcos, you know, 5 Vicodin. You don't need 50. You don't even need 30. You might not even need 10. But having a couple of Norcos on hand that you can cut in half or cut into quarters to use for 24 hours or 48 hours after a hydrodistension, I think is completely reasonable. Okay, so that's me. I think you can say to the doctor, listen, I'm not asking for 30. Give me 5 pills. And this is how I'm going to use them. And I think you and I can agree that, yeah, I'm not going to become an addict to an opiate with 5 pills. Or give me 3 pills and I'll cut it into quarters and then I'll have 12 total units that I can deal with. I can really rant on that. I chaired our State of California Pain Conference several years ago and had a lot of opportunity to work with the DEA and pain specialists at all the universities. It was very interesting. Chris says, she was just diagnosed with macular dystrophy. They can't figure out why she has macular dystrophy. She hadn't taken Elmeron in years. Well, so Chris, macular dystrophy is either genetic and inherited, and they can do some genetic studies to see if it came down from your family, or in all likelihood, it might have actually been that you used Elmeron. Elmeron, they now believe, builds up on the retina and can cause macular dystrophy. If you come onto our website, I have a blog on it right on the front page. Maribel said that she took Visceral and anxiety medication. You were always sleepy because you took it 3 times a day. That's why you don't take hydroxyzine Visceral during the day, as it can make you sleepy. Normally, IC patients will take Visceral the night before, around dinner time, about 4 hours before you go to bed. So you've got enough time for the Visceral to get into your bloodstream to help you sleep. But it's actually pretty rare that you would take it during the day unless it's a very extreme situation. Wendy wants to know the name. Cystoprotec. Liz says, my urologist went straight from Elmeron to bladder Botox. Meanwhile, I told him my pain was about a 4 at best, a 6 during a flare, 4 at best, 6 during a 6 during flares are the worst. All of your pain is in the urethra, and it's normally always a week before your period. You follow the IC diet religiously. So, Liz, I have a blog on our website called The 7 Causes of Urethral Pain. I want you to go read that. Right on the website, just search for urethra, and you will find a blog called The 7 Causes of Urethral Pain. Just to summarize, the urethra is often the first part of the urinary tract to react to the loss of estrogen. So if you are estrogen deprived in any way from a hysterectomy or birth control or whatever, your urethra may not have enough protective coating. And, you know, because your urethra is just like your bladder, it relies on a layer of mucus. And this mucus is estrogen dependent. When you're young and you have a lot of estrogen, you have a lot of mucus. When you're older, you have less estrogen, you have less mucus. Thus, your urethra is more vulnerable. You also want to look at chemicals, and chemicals from douches to bubble baths to laundry detergent to fabric softener to dryer sheets. Those are all well known to release chemicals that will hit that urethra hard and cause urethral pain. Another thing that we want to look at is Could you have an infection of the periurethral gland? Your urethra is kind of like the size of your little finger. So it's about 2.5 inches long. About halfway up is a gland on the outside of it that's like a little sea sponge. And believe it or not, it's the female prostate gland, but we call it the periurethral gland. And just like in men, the female prostate is known at times for becoming infected. And the problem with prostate tissue is that their drainage ducts are tiny and are easily blocked. And so sometimes what happens is women can get a little pimple or a little infection in this gland that is actually filled with lots of different bacteria and biofilms. So the way they would figure out, and you can figure out if you have a periurethral gland infection just by sticking a clean finger in your vagina, right, and rub across the front right about an inch up. Because remember, your urethra is this big. So all you got to do is stick your finger in your vagina about this far and gently touch the front side of your vagina where your urethra is. And if you feel any tender spots, it's kind of like the consistency of a green pea or a deep pimple, then you have an infection in your periurethral gland. And what they would do is they would go in and they need to press it out. So that usually involves a finger, doctor's finger in your vagina and a instrument in your urethra, and they kind of squeeze it like a pimple to try to drain it. I've worked with patients who have had it done. In fact, the very first article I ever put on the IC Network when I built it in 1994 was an article from UCLA on the female prostate gland. I still have it on the website somewhere. Sherry is at the Phoenix airport waiting for a flight to Dallas. Wishing you a good flight, Sherry. Dee says she takes 2 hydroxyzine twice a day plus amitriptyline a night. I could never do that. It made me way too sleepy. I only took it at night. Hello, James Franklin. Very nice to see you. Hope your ankle's doing well. You have been through some surgery, my friend. I'm just reading your questions here, guys. Kim says she stopped Elmeron and her vision improved 100%. Awesome. Really glad to hear that. She replaced Elmeron with prophylactic antibiotics and you're staying away from trigger foods. I don't know about the prophylactic antibiotics. It's really not done so much anymore. That's pretty much discouraged because of the risk of developing more drug-resistant infections as well as C. diff. So you'll see in the AUA guidelines for IC that they do not suggest doing that. So that's interesting that a doctor has you doing that. Julie says she doesn't have any emotional support from your family. I'm so sorry, hon. I'm giving you a hug right now. You got support here, girl. You got support here. Oh, Dee is a patient of Dr. Carl Creeder. Awesome. Okay, it's time for my reveal. I have a reveal for you guys. So, you all know that chocolate is a wicked irritant for IC. This is right. So the name of this company is Surprise Foods. And I have known them for a couple of years. And their specialty is not only chocolate, but carob. Now, the carob today is not the carob of years ago. The carob and chocolate both come from the bark of trees in Africa, the cacao tree, and also the carob tree. I think it's called, and there might be another name for carob. Anyway, it's carob. So it's the same principle. They both come from basically the equivalent of very flavorful tree bark. back in the 70s and 80s, carob was disgusting because it was lesser. Nobody played with carob because you had chocolate. Today, we now know that tons and tons of people have issues with chocolate. And so we now have manufacturers who are doing an incredible job with carob. And Surprise Foods, I'm telling you, nailed it out of the park. Incredible. If you are a former chocoholic and you miss your chocolate, I double dog dare you to try these carob bars. And they're made with organic maple syrup, gluten-free flour, which includes rice flour, potato flour, tapioca, little tiny bit of psyllium husk, organic honey, little whipping cream, butter, organic carob powder, egg whites, maple sugar, organic cocoa butter. No, I'm not saying that right. I can't see that. I can't read that part. It's a little blurry. Okay. Here it is. I'm telling you, I have not been able to eat chocolate in 25 years. I get the worst bowel spasms ever, ever, ever. I can eat these. Look at the texture. Super soft. Super soft. And what the cool thing about it is, you only need one at the end of the day, and your sweet is over. You know that whole thing, you crave something sweet after dinner? There you go. Totally chocolatey, really rich, really flavorful. Love, 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 love it. And they're not paying me to say this. Whenever I find a product that I think an IC patient will enjoy, I want you to try it. And so this carob bar, if you have anybody in your family that misses chocolate, we even gave this to the teenagers in our family. They had no clue it wasn't chocolate. Incredible. Oh my God, I could eat a whole box of them, but I'm not gonna. One a day. One a day. So I'm gonna, and they come frozen. I keep them in the freezer. And so this one is just gently defrosted. It doesn't turn color. It doesn't get slimy. It's like the bomb. Perfect for the holidays. So you can go to their website and just Google Surprise Foods, and they sell them in bulk. You can get them in a box like this or a bigger box. Or we actually will be selling them through the IC network. I have them already in our freezers up at our warehouse. I'll have it up on the website tomorrow. We would only do this during the winter and the spring. We can't ship any carob during the summer. But anyway, for anybody who is a massive chocoholic, I double dog dare you to try these gluten-free carob bars made with maple syrup. They are incredible. All righty. Let's go back to your questions. Oh, wait a second. And my friends, I have a giveaway. Oh, I have a giveaway. And hold on, I got to get my Post-it and I got to write it down. We finally got our inventory of these. This fabulous new book written by Dr. Angie Storr from Texas about pelvic pain. This will teach you more about pelvic pain and how to prevent pelvic pain than any other book we've ever read. I think it's phenomenal. It's just literally must reading for anybody with IC who struggles with pain. So I'm going to give one of these away. We're giving them away. No, you know what? I'm not giving one away. I'm giving 5 away. For you coming to this meeting, I'm giving 5 away. So the first 5 people who email me their snail mail address is going to get a free book from me. And hold on, let me get you the email address. Where is it? So open up your email right now. Put your mail. Don't just say you want it. Please, please. You got to put your mailing address in there. And hold on, hold on. I will give you the mailing address. Some of you might already know it. Where is it? I have all these slides here. Here it is. All righty, first 5. icnetwork@mac.com. icnetwork@mac.com. First 5 of you who send me an email, I'm going to send you this fabulous book, When It Hurts, down there. All righty? I promise you, you're going to love it. And for those of you who pass, we're going to have it in our store for $24.99. And we're the only ones selling it in print. You can also go to her website, whenithurts.com, and you can order an ebook for $19. But we're going to sell the print one for $5 more, $24.99. All right. Michelle asks, have you or any other patients you know had success with pelvic floor nerve blocks? Yes, definitely worth trying. Definitely worth trying. Maureen asks, is Cysto Renew the same as Cysto Protect? No. Cysto Renew is actually a better formula than Cysto Protect. We had been waiting for, Cysto Protect is an old formula. It was created almost 20 years ago. And we have been waiting for Dr. Theoharides to create his next generation supplement based upon some of the new research we have on IC. But he's moved on. He's doing other things. And so a new doctor, Dr. Gio Espinosa, he is the director of integrative urology at New York University. He created the next generation supplement. And it is in my opinion, a better formula than Cysto Protect because it has more methods of action. So this is Cysto Renew. So both of these have chondroitin for a bladder coating effect combined with quercetin for an antihistaminic effect. And Cysto Protect actually has another bladder coating in it called hyaluronate, okay? So what Dr. Gio did though, is he took the best of all the supplements on the market and put them in one pill. So this one has some of the same ingredients. It's got chondroitin for the bladder coating effect, quercetin for the antihistaminic effect. It has aloe for the soothing effect of aloe. It has L-arginine in it and L-citrulline. But the ingredient that makes this very unique is it also has a mint in it called lemon balm. It's not citrus lemon, it's lemon balm. And lemon balm is known for its calming and soothing effect on nerves. And that's where a lot of IC research has been in the last 5 to 10 years is how do we calm irritated nerves in the bladder? So I believe that Cysto Renew is truly the next generation formula that's currently available on the market. I will tell you, though, we have a new team that is putting together a new supplement line that I think will probably be even better. And I will have more information on that. I'm actually helping them. I will have more information on that when it's available. Patricia has had IC for 16 years. You've been pain-free for 5 years. Oh, I'm so glad to hear that, Patricia. And thank you for your compliment. I appreciate it. Guys, if you like these support group meetings, we need your help. Can't do it without you. We need people to subscribe to our magazine, the IC Optimist. Please become a member of the IC Network. You can do that for as little as $25 a year. And that's what makes these meetings happen. So it makes everything happen. Without members, we are screwed. So please be a member. You know, a lot of the money that used to support IC outreach is gone. The pharmaceutical companies have disappeared. They've all bought each other out. And there are really only 2 pharmaceutical companies that are working on IC products, both of which do not support anything with respect to IC outreach. Janssen Pharmaceutica is a company that owns Elmeron. They've done nothing with IC outreach in a decade. And then we've got Mylan Pharmaceuticals that currently owns Rimso 50, and they just canceled Rimso 50 in Canada. That was discontinued. They also own Cystistat. That's in Canada, not available in the US. So, and the other company that we had great hopes for with respect to new treatment for IC called Equinox Pharmaceuticals, they had a drug called Rosiptor that we had been doing clinical trial recruitment on for 3 years. Many of you here probably participated in that research study. Sadly, it failed, and they shut down the IC arm of that company, fired everybody, shut down the prostatitis arm of that study. The company lost 95% of its value last June when the research results were in. So there is no corporate funding right now for anything related to IC. And so the only thing that makes the IC network happen is members and our store. We get to sell things, and that's good. So we really, truly need your help. It's quite depressing sometimes when I think about it. There's so much I'd like to do that we can't do because we just don't have the money for it. Patricia says, for her, it was changing her diet, less stress, and physical therapy was the game changer. Stephanie said she had her first bladder rescue treatment today. 10 cc's of Marcaine, 1 cc of heparin. Doctor is 2 hours away, so we discussed me doing these at home. Does anyone do that? Oh, Stephanie, it's very common for patients to do it at home. Home installations are common. They will teach you how to do it at your doctor's office. The only thing that I would say to you is you really have to practice sterile technique. You should not be reusing catheters, and you have to wash your hands really carefully and try to keep yourself as clean as possible. The major risk of doing home instills is just the risk of infection. Christine asks, are Care bars available in Canada? I'm sure we can ship them to Canada. Julie, how much is a Care bar? Oh, I don't know off the top of my head. I know that if you get a 10-pack of 20, it's like $24, but we're going to sell them in 2-packs or 4-packs. I have them. We just got them. I just haven't put them in the store, so I don't have the right answer for you. I'm sorry, but I will soon. Taryn says she was offered treatments at home, but you were scared because they always check your urine. Can't do that at home. You can check your urine at home, Taryn, with a home UTI test kit. I mean, it's not the end all. It's not a next generation test, but it will at least give you a clue if anything's going on. A next generation test, you just pee on a stick. It has 2 pads, the top one for leukocytes, the bottom one for nitrites. If you have a double positive or a positive nitrite, yeah, you have infection. If you have a negative nitrite and you're positive leukocytes, probably just a flare. And if you've got a double negative, you got nothing to worry about. Sean says, cannot find any clinical trials either. Actually, we have a new, I was going through it yesterday because I was going through the latest research. There is a new medication that it looks like it's just going to enter clinical trials. Let me see if I can get you the name of it. I'm just learning about it myself. Hold on a sec. I just go into the National Library of Medicine and let me see if I can find it. Here it is. I don't know anything about this yet. But hold on a sec. So this is the first time I'd seen it in an IC study, unless I'm blind. It's called Cimzia, C-I-M-Z-I-A, Cimzia. The scientific name is certolizumab. You can't make that stuff up. Certolizumab, PGAD. And Cimzia is used for rheumatoid arthritis. And we have a research team that actually tried it with interstitial cystitis. And let me just tell you what the results were. Hold on a sec. I literally stopped myself from doing an article on this. I wanted to get my magazine out. So we'll do an article on it in our winter magazine. But let me find that study here real quick. Here it is. It's published in the European Urology magazine, and it was done at UC San Diego, and it was to evaluate the efficacy and safety of this medication compared with placebo in women with refractory IC. And the conclusion was women with moderate to severe refractory IC were more likely to experience significant improvement in symptoms compared with placebo. Further investigation for the treatment is warranted with a larger, longer, multi-center, randomized, placebo-controlled trial. So I'm going to be all over that and reach out to that company and see if we can help them. Julie says she tried Cystistat years ago, but with no success. Cystistat is a liquid hyaluronic acid. Julie, astonishingly, I called, when we learned that RIMSO 50 was canceled in Canada, I called Mylan to ask why. And then I asked them about Cystistat and what their plans were with Cystistat. They couldn't even find it in their records. They didn't even know they had it, the people that I talked to. So I don't know about the future of Cystistat. Alexis asked a very good question. She read the IC guidelines and she saw that a hydrodistension with cystoscopy was actually listed as a third-line treatment for IC, and that is true. However, that is under debate. So here's what we know. When you stretch the bladder wall, you break nerves, right? I mean, because if your bladder is normally like this, and let's just pretend my fingers are nerves, if you stretch it, the nerves break. And so we have long known that patients have had hydrodistensions, and they have been stunned to find after they recover from it that their symptoms are much, much better, that they don't have pain. Why? They don't have pain because the nerves are broken, but that's temporary. The nerves always grow back. And sometimes more nerves grow back. And so hydrodistension as a therapy is what I call a destructive therapy. It's not healing anything. It's damaging something so you don't feel pain. And so there is, I would say, a very strong trend to no longer use hydrodistension as a therapy, although there is a small group of patients, including Donna, who runs the ICN support forum over on our website. She does them and has done them with success. But generally, the trend now is not to do that. Let's see here. I'm just checking YouTube here. Lizzie says, Lord, thank you. I have found my people. You have extreme pain every day due to IC and uterine cancer. That was me last year. I had uterine cancer last year too. Lindsay, I'd love to talk to you. If you ever want to talk by phone, you guys feel free to give me a phone call. I have days when I'm on deadline and I can't take phone calls, but I do try to call everybody back. You can call the IC network at 1-800-928-7496. I'd love to talk with you and hear you more about what's going on with your IC and your uterine cancer or your hysterectomy. I will tell you that my pelvic floor has been really a mess since my hysterectomy, and it's extremely frustrating. And I'm in physical therapy to try to deal with those surgical adhesions. So it's a bit of a beast. Isabella asked, do Hunner's lesions bleed? Yes, Hunner's lesions are known for bleeding, so much so that they call it a waterfall effect. That when you have a Hunner's lesions and you stretch it with water, it will bleed profusely. And so any girl, any man or woman who has blood in their urine, that you can see visibly, that is an immediate call to your doctor. And if it's consistent, you definitely want them to look in your bladder to see if you have bleeding Hunner's lesions, because they will need to be cauterized just like you would cauterize a bleeding nose. They can cauterize it to stop that bleeding. Isabella asked, well, is it better to treat lesions by burning them off or by cortisone? Cortisone. The downside of the lesion of the laser therapy or the fulguration is you leave scar tissue, and that scar tissue is not as flexible as normal skin. So what will happen is your bladder will not be able to stretch as much to hold urine if you have fulguration or laser therapy. Whereas if they do the steroid injection, it has equally effective, but it does not leave scar tissue behind. And so most people start with the steroid injection, but ultimately it's up to that doctor's confidence level. Some doctors, like Robert Moldwin, is a master with the laser. He teaches all the different laser techniques that can be used. And so it's kind of up to doctor training, doctor preference. But you should also know that we have the first treatment that has healed Hunner's lesions in just 2 weeks. It's called Lyris, also known as the lidocaine pretzel. And that really, we hope, is the future of Hunner's lesion treatment. The company that currently has it is Allergan. They were supposed to release their latest clinical trial results in September. We have not had them yet. I don't know what they are, and I've reached out and they have not gotten back to me. But there's a lot of excitement for Hunner's lesion treatment. Loane says, can you recommend a good IC doctor near South Texas? I can tell you San Antonio Urology has pretty good urology clinic. If you're over by Houston, you want to look at Baylor. Dr. Chris Smith would be the ones that come to mind. We have a doctor database on our website. You can put your zip code in, and you can search 5, 10, 20, 50, 100 miles away to find people. I will tell you our database is a little bit out of date. I have about 200 doctors to add. I had a staffer who was supposed to be doing it, and she just mysteriously decided to stop working. So that's on my massive to-do list, is to find somebody who can help me do that with my letters to the new doctors. Betty Price says she's been told that you have Hunner's lesions. You haven't been told that I have IC. Finding you has been informative. I don't know what to do first. Do I start my diet first? Hell yeah, start your diet. Oh my God, yeah. You've got wounds in your bladder, girl. And the last thing you want to do is pour acid on a wound. So diet is absolutely essential for you. And then at the same time, know that your long-term goal is to get those Hunner's lesions treated correctly. We have on our website a lot of good information on diet, a lot of good information on Hunner's lesion therapy. If the Lyris treatment comes back out, you're definitely going to want to look at that, participate in that clinical trial, because that's the most encouraging thing we've had for lesions in 25 years. But in the meantime, your goal is to not irritate it further, and that means you've got to follow the diet. And if your symptoms are off the charts and you're in a lot of pain or discomfort right now, getting those lesions treated with a steroid injection or with a laser therapy is going to be your priority. You don't want to waste your time with oral meds. Oral meds like Elmeron are not going to be effective against a Hunner's lesion. I don't know anybody who thinks they are. So the 3 treatments for Hunner's lesions are fulguration or laser therapy, triamcinolone injection, or Lyris, the lidocaine pretzel. Getting dark here. You can see that everything is weird. I have a light here. I don't know if that would make it better. I don't know. Does that make it better? All right. Lindsay says, yes, 3 years later, your pelvic floor is cement. Yeah, girl, I feel your pain. Isabel asks, how long do you give a medication a try to see if it's helping? You know, the bladder is the slowest healing organ in the body. You cannot expect anything to work overnight. It takes 2 weeks for one cell to be replaced. So at a minimum 6 weeks, but really 3 months, 6 months is ideal. With Elmeron, some people say it took a year for them to get help with it. I don't know about that. You know, I'm really kind of the 3-month girl, 6 to 3 months, 6 weeks to 3 months. Obviously, if you're having a side effect that is impacting your quality of life, with like diarrhea or something like that, that might encourage you to discontinue that medication. You know, a medication should not interfere with your quality of life. If a medication isn't interfering with your quality of life, then it's not the medication for you. Buprenorphine. All right. So Angie's saying that pain management put her on a new med, buprenorphine. Hold on a sec. That's a new one for me. Also known as Subutex. Let's take a look at that. Let's see what side effects there are with that. So it is a prescription drug used to treat dependence on opioid painkillers, such as OxyContin. It can be used to treat post-op pain. It works on your nervous system. It's also used to treat some narcotic pain addictions. Yeah, that light didn't work. All right. Sorry about that. We're gonna end soon. It's too dark. Can slow your breathing. See what the side effects are with that. Headache, stomach pain, constipation, vomiting, difficulty sweating, dizziness, nausea, increased sweating, headache, blurred vision, serious side effects. Hives, skin rash, itching, difficulty breathing. And a serious side effect is urinating less than usual or not at all. So it looks like it can have some effects on the bladder. I would suggest that you Google it or look at the drug sheet that came with your prescription, and let's see what it has to say. And then you got to be on top of that and see if you have any of those side effects. Sonia said she had her bladder wall scraped in 2000 when you were first diagnosed, and it worked. You had no problems for 5 years. Yeah, no, we don't do that. You know, now that we think of I see more as injury, the last thing we want to do is scrape off the entire bladder and create one big injury. There are a lot of reasons why we could say that it worked. I mean, you may have just grown a new healthy bladder wall, but that doesn't necessarily help us understand why you had IC in the first place. Could it have been, you know, pelvic floor dysfunction? Could it have been poor blood supply? Could it have been cough irritation? We just don't know. But we don't do bladder scraping anymore. What is considered a low hydrodistension? I think my last one was around 1,000 ml. Hun, check the AUA guidelines. I don't remember off the top of my head. Nancy says, the estrogen drops from the Women's International Pharmacy have helped a lot. Thank you. My urethra is no longer burning. Yes! Yes, yes, yes. I love success stories like that. Awesome. Awesome, awesome, awesome. Awesome. All right, my friends, listen, it is 5:30 here in California, and I've got elderly parents that I've got to feed. So I think we're going to wrap this up. We send my meetings in 2 ways. Number one, again, if you found this helpful, would you please come over to our website and become a member of the IC Network for $25 a year? That would be very, very helpful. Keep these meetings happening. Make sure that you like this Facebook page or you subscribe to this YouTube channel so that you can get notifications when we go live for these random meetings. Remember, we have 2 scheduled meetings, first and third Sunday of the month at 12:30 Pacific. But I also am well known for just doing meetings randomly. And I'm gonna try to actually do quite a few meetings in December during the holidays because I think y'all need it. And I think the more we can be here together and support each other, I think is important. So I'll probably be doing some random meetings in the coming weeks also, more so than usual. And then last but not least, I always end these with the single most important thing I want you to remember from this meeting tonight is this is not your fault. You have done absolutely nothing wrong. I don't want you carrying any shame. I don't want you carrying any blame. I don't want you feeling lesser. I don't want you feeling like you're damaged goods. I don't want you thinking that you're a bad mother or a bad father or a bad daughter or sister. None of that is true. You are hurt. You are injured. And you're going to be, listen, I know you because I'm you, right? If you have somebody in your home who has fallen and broken their leg, not only are you getting in the car and taking them to the emergency room, you are going to sit there with them. You are going to bring them home with the cast. You are going to be bringing them food on the couch, and you're going to be loving on them for weeks while they heal. But why don't you think you deserve the same thing? So interesting that we don't think we deserve the love and support of our family members. And we do. And you do. And so I don't want you to hide it. I want you to ask for help when you need it. No shame, no blame. And if you have someone who does not believe that IC is real, why don't you show them one of these videos? Or why don't you show them a magazine or bring them on our website? You know, I have sat for the last 8 years on the U.S. Army IC research panel. The U.S. government has put $100 million into studying IC, and we have made fabulous strides forward in understanding this. We no longer think, you know, I mean, here's the deal. IC was first really thoroughly discussed in England in the 1800s, where you look at a patient description in England in the 1800s, and it is perfect for somebody, any one of you today. And then in the 1920s, a doctor named Guy Hunter invented the cystoscope. And for the first time, we could look inside the bladder. And they found Hunter's lesions, which is why they're named after Guy Hunter, right? So we knew there was physical damage causing symptoms. And then around World War II, we had our first research studies that show that men and children can also get IC, right? Again, physical structural damage to the bladder. But then in the 1950s, two arrogant pricks of doctors wrote a case study of a woman with quote unquote IC symptoms. And they claimed that she had unexpressed anger manifested in the pelvis and referred her to psychiatry. And from that moment all the way up to 1990, medical schools often taught doctors that IC was all in their heads. That's what they taught Dan Burkhoff. If you've ever heard the name Dr. Dan Burkhoff, Dr. Dan Burkhoff was a nation specialist in pain for many, many years until he passed away a few years ago. And he used to describe how he was introduced to IC. It was at a seminar on urology while he was in med school. It was a very famous doctor teaching it. And literally at the end of the day, the doctor's grabbing his briefcase, putting everything together, getting to go, and he stops and he turns back to the crowd and said, "Oh, wait a second. There's something I need to tell you about. It's called interstitial cystitis. You're going to hate these patients. They're going to be the bane of your lives. And it's all in their heads." And so the doctor sitting next to Dan Burkhoff raised his hand and said, "Well, how do you treat it?" And the doctor on the stadium said, "You remove their bladder." And the student said, "But wait a second, if it's all in their heads, why would you remove their bladder?" Right? And that doctor was thoroughly humiliated in front of this young group of medical school students because he could not explain that. It would be malpractice to remove the bladder in somebody if they had a mental problem, right? So we are now dealing with the legacy of this blame. I have worked with patients myself. One, a very good friend of mine who was actually tied to a gurney and driven 4 hours to a mental hospital 15 years ago because they thought her IC was all in her head. And here you can imagine, she's wicked IC, like wicked pain. She is writhing, begging them to let her use a bathroom. Please let me go to the bathroom. They refused. And then they get to the psych hospital and they follow her into the bathroom and say, you cannot pee without us watching because we need to know what you're doing. And so she lets it go, right? She lets it go. She's bawling her eyes out. An hour later, the head of the psych unit comes back in and apologizes to her and says, we're so sorry. You have a real medical disease and this should have never happened to you. And that's one of the reasons why IC Awareness Month is so important, is because we have to stop things like that. There are still patients, I talked with one this week, who was still told something like that, that it was all in their head. It happens every day. And that's just from these two pricks of doctors in the 50s who put that out there. IC is real. IC is treatable. There is no doubt about it. There are 5 subtypes. None of this are you making up in any way, shape, or form. And so your weapon is the AUA guidelines. If you go to the AUA website, again, I said this earlier, I want you to go to auanet.org. And the upper right-hand corner is a link called Guidelines. Go there, search for interstitial cystitis, print it out, print 3 copies, one for you, one for your urologist, and one for the emergency room if you have to go to the emergency room. And if anybody has the audacity to tell you it's all in their heads, you whip that sucker out and you give it to them. And say, I'm sorry, I'm going to beg to disagree. The American Urology Association and the National Institutes of Health absolutely believe that this is real. And here is a treatment protocol for it. And here is how they want you to treat pain. Because it has a beautiful section on pain management, and they support the use of opiate pain medicine, along with other things, but they support the use of opiate pain medicine. And don't walk away from medical marijuana. If medical marijuana is available in your area and your doctor's not giving you pain meds, consider the medical marijuana. It's helping a lot of patients. We've had a decade-long study on IC patients using medical marijuana on our website. I publish the results, updated results every 2 years or so. Okay, so that's my little rant for you. That's my little history medicine for you. But please, please, please remember, it's the holidays. I want you to be kind. I want you to be gentle to yourself, but I also want you to stand up firm for yourself. Be willing to defend yourself, not with crazy words on Facebook. Don't fight somebody with swear words. Hand them the facts. Just hand them the facts. Hand them the guidelines. Not only will you help them, but especially if you give it to a doctor, especially in an emergency room, you're going to help them treat other patients. So you are our ambassador for the IC world. And the more people you educate, the more patients you're going to help down the line. And that is something you need, my friends. That is a tremendous gift that you are going to give to the IC world. All righty. All right, everybody. Be well. And I will see you this Sunday for our first meeting of December. All right. Have a nice day or evening and sleep well. Bye-bye. All right. Facebook is shut down. YouTube, you are on. Let me just see if you have any other questions on YouTube. Betty, I would be happy to talk with you about your biopsy and kind of what you're doing. If you'd like to give me a call sometime this week or next. But our website has really good information on Hunner's lesions. That's a good way to start. But I'd be happy to talk with you a little bit more. Isabella, ozone installations, pretty controversial. We've got some anecdotal data from one doctor saying they're beneficial. Not being used in any great degree across the country or across the world. We need a little bit more information about it and about the safety associated with it. Okay, so it's not something you'll find in the guidelines. And again, there's only one doctor who is doing it, and I think she was in Colorado. She just shut down her practice in the last couple of months, and I don't know of anybody who's doing it now. All righty. But if you know anybody, let me know. I'd like to hear more about what they're doing. It's very, very controversial at this point in time. Okay. All right, my friends, be well. Talk to you later.